Hola, buenos días. Soy Bibiana, como siempre, acá introduciendo al doctor Perry Schoenecker. Esta vez nos acompañan el doctor Juan Albarracín, el doctor Javier Masquijo, el doctor Jorge Castellini, desde aquí de Argentina, y los doctores Johnson, Buster Willis, y por supuesto Perry, desde Estados Unidos y Canadá. Vamos a dar comienzo al tratamiento quirúrgico de las barras tarsales y el pie cavo. Adelante, Perry.
Thank you very, very much, Lydia. And I welcome everybody to our 8th Zoom conference, coordinated between the Garrahan Children's Hospital of Buenos Aires and Washington University Orthopedics, surgical treatment of tarsal coalition and CAVUS foot deformity. Great thanks again to Bibiana, who keeps us going on this. It's a pleasure to be able to participate. So faculty from North America, United Kingdom, and China, Jeff Johnson from St. Louis, Baxter Willis from Ottawa. Results, a very busy surgeon who just called in from Detroit, Michigan, who is doing trauma this morning, but hopefully will join us. Peter Stevens, I don't think has checked in yet, maybe. Deborah Eastwood from United Kingdom is, I think, joining us soon. And hopefully Shuman Liu from Beijing will chime in when he can. And faculty from South America, Bibiana Dello Russo, you all know, Dr. Castellini, Javi Masquijo, we all know from Cordoba, and Juan, who is also, I believe, from Buenos Aires. So we welcome everybody to what should be a fun, interesting morning. And special thanks to Lydia and also Marina, our voices of which we recognize this program. Their technical efforts make this possible. Without them, this would not be what it is. I want everybody to understand it. Sabrina has been the backbone of our organization with the Zoom organization. So thank you, Sabrina. And somebody you never see on this call, but works with me hours after hours on the details of trying to get the slides such that they're user-friendly for everybody. If you have some conflict, money interest, intellectual with the foot, speak at this time. I would question your sanity if you have any conflict with the foot. So anyway, tarsal coalition can be calcaneonavicular, as we see on this oblique x-ray, and talocalcaneal, and it can be others, but these will be the two we will discuss this morning. And I think, as I've given this default before, Dr. Johnson was the first one to point out to me, the question really is, Perry, which ones are resectable and which ones should be left alone, treated in some other technical fashion other than resecting. So let's talk about talocalcaneal. So just for discussion, I'm going to say this 14-year-old boy has a fibrocartilaginous coalition. It looks kind of bony, but let's call it fibrocartilaginous. It's the middle facet, which you see best and only see definitively on some sort of 3D picture. I prefer CT. Some others might prefer MR. And in this particular case, it's not a standing CT, but there's no notable foot deformity on radiograph or in clinical exam. So let's go through the operative treatment of this, which is what the discussion is this morning. There could be non-operative treatment in your algorithm approaching these problems, but we're going to talk about the technical issues. So I have pictures from appropriate to this particular deformity. And this is the incision we use, the medial oblique incision centered over the talocalcaneal joint. And you make the incision and you find the posterior tib tendon and you think that's where the coalition is. The common toe flexors And as much as you like to expose, sometimes the neurovascular bundle are posterior, as we see in the left corner of the slide. You need to resect bony type tissue. And from my personal experience, time after time, it's not always obvious just exactly where you're supposed to go here, because you sort of face a wall of tissue that's mostly bone. And you kind of say, where are we? I just suggest be patient. Sometimes take an x-ray, put a small wire where you think the subtalar joint is. So to go around and have discussion, Baxter, any clues here on assuring that your approach will get you to the subtalar joint? Share with us.
Well, a couple of tricks, but if you note on the CT scans, there's always a protuberance at this middle facet. So you want to find out where the bone is protuberant on the medial side, as you see on that CT scan. And that's going to be a hint that you're at the middle facet area. And then if we are having problems, I would go with your approach. Put a wire in where you think you're going to go and take an axial view intraoperatively. It's going to give you a hint that you're in the right area, because this is problematic. You have to resect a lot of bone. And I think if you haven't had the experience of doing this a few times, you think, this can't be right. I can't be excising all this bone to resect this coalition, but you have to resect a lot.
Had I been asked the question, I would have answered exactly the same way. So be patient. Eventually the joint is almost there, and it's like suddenly Christopher Columbus discovers, land. You find something. Oh my gosh, that's where we want to be. So then you keep dissecting, and you carefully might use a laminar spreader to open things up a little bit. When you do that, be careful you don't break off the sustentaculum tali down here. I've done that before, being a little too aggressive. And I like to make a posterior capsule incision in the subtalar joint. I learned to be very comfortable operating in this area, doing clubfoot releases a la Turco, too much release, but we learned that decades ago. The bundles back here, when you do this, on the saw bones, we're somewhat in this area. Deborah, are you on the call?
I am.
Any additional comments here about getting the exposure and then getting the joint to open up a little bit, and tricks that you use that are helpful?
I think it's just a matter of, as you say, finding that posterior facet. So I often find that first, because if I'm having trouble finding the coalition, I go back posterior to try and find the joint first, and then work forwards to excise the coalition. But yes, I use the laminar spreader if I can get that in as well.
So we've gotten that far, and then we open up, and then we have the usual debate for 2 or 3 minutes. Should we put anything in there? Should we wish for no reoccurrence? Should we use bone wax? Should you use fat? Something to put in there to keep this from happening. In this case, I took fat, as Dr. Mosquijo will tell us, as he does, from the gluteal crease. You can take it from the inguinal crease in front. You can try to harvest it from the ankle area where you are, the foot. I show that here. Does it, as far as you're concerned, Bibiana, make a difference if you put anything in there? Do you think, Dr. Dello Russo?
Nosotros creemos que siempre ponemos grasa, siempre ponemos algo que interponga.
Dr. Mosquijo, have you not reported on this a little bit in the literature?
Yeah, we usually use fat, and we found that in the calcaneonavicular coalitions, the fat decreases the risk of recurrence of the
How about the
coalition.
subtail? How about the middle facet coalition?
That's a different animal, and I'm not sure. I can't answer on scientific evidence, but it's my preference to use fat because we have had some issues with bone wax related to foreign body reactions. So I don't use bone wax.
Probably one of the most, Dr. Johnson, what are your thoughts about to put something in here or not? Jeff Johnson.
Well, I don't personally have enough experience with enough cases doing different things that I can really tell you from my own experience. I think something makes sense. Typically, bone wax has been something that's been used here. There have been a number of papers in the adult literature in the US that suggest that bone wax is as good as this. But as Javier says, there are occasional people that will get some reaction. I'm never really sure if it's the bone wax or not. I think early motion is probably one of the more important things, but I think it makes some sense. I have done just exactly as you've done here, buttock fat, as you, Perry, have taught me, and I've placed that in there. But to tell you the truth, I'm not sure if anybody really knows.
Dr. Castellini or Juan Pablo, have any of you in Argentina used what was published a few years ago? You let the toe flexors slide into that and leave that in there? That was actually published. Has anybody done that? Does everyone remember? That was published a few years ago. Not from, I mean, it was from North America, someplace.
Not done it deliberately.
Yeah, I don't think so.
Me ha pasado usar grasa y el flexor largo como interposición. También me pasó hace muchos años que haciendo una resección hice una resección tan amplia que resequé el subtentáculo en tali. Y después John Davis publicó un trabajo donde era una opción resecar el subtentáculo en tali para que quede más libre. Quería saber si Perry tiene experiencia en eso.
Yo en particular he ido abandonando la idea de operar estos casos. Trato de ver evidente, digamos, el diagnóstico clínico, porque los resultados que hemos tenido interponiendo, en pocos casos, pero tanto interponiendo como no interponiendo material, hemos tenido muchas dificultades con el resultado clínico. Es decir, muchos pacientes continúan con dolor, lo que me ha ido llevando a reducir la indicación quirúrgica, a pesar de que pareciera que es lo que hay que hacer.
I have not stopped operating on these. The more arthritis or changes, the older the patient, the less I think the predictably satisfactory outcome. I'm going to show a case here in a little while where the coalition was so big, we decided not to operate on it. That's as close as I can get to commenting on it. Deborah Eastwood from London, are you still thinking middle facet coalition in the correctly selected patient is a good idea or a bad idea?
I still do it, and I therefore must think it's worthwhile. But you can tell by my voice that I'm not totally confident about it. But
Yes, we would, Perry. I think where we've changed in the last 10 or 15 years is doing the resection and at the same time considering any other flat foot reconstruction in conjunction with it at the same time. Whereas previously we used to just do the resection and probably didn't have as good a results as we would have liked.
That's a nice segue to move on here. So this is my post-op regimen, and right or wrong, I go for early motion. I put these patients on non-steroidal anti-inflammatories with maybe the correct idea or a delusion that I may be minimizing recurrent bone formation. I let the patient sort of determine when they start weight bearing. This is for one without significant deformity. To keep us moving here, let's go to Javi's patient, a younger patient, Dr. Mosquijo's patient, 10+3. He's saying this is a rigid flat foot. I've changed his words a little bit. Pain with activities. In your experience, Javi, I know you like to doing this operation. You show some nice cases. Is the pain typically localized in a young patient to where the coalition is, let's say for the middle facet? Is that yes or no?
Yeah, I think the pain can be localized on the coalition if it is a fibrocartilaginous coalition. But if the coalition is associated with severe deformity, the pain can be located on the lateral aspect of the foot because of impingement between the calcaneus and the fibula, or could be at the sinus tarsi. So different places. Usually, if the pain is located on the coalition, indicates that the problem is there. But if it is associated with deformity, usually the pain can be also on the lateral side of the foot.
In your experience with little older patients, is that typically the case, Dr. Johnson?
Well, I think if it's a fibrocartilaginous coalition, it can be tender there. I think for me, the biggest thing is there deformity or is there no deformity? And I think that it's hard, I think, to separate what effect the deformity has. So I always want to correct the deformity. And then depending on the situation, if it's a very stiff joint, arthritic changes already, I might either leave it alone or do a subtalar fusion at that time. But I think the older the patient and if it's a talocalcaneal coalition, I just think it's much more unpredictable as to whether you're going to get any motion at all and whether there's going to be pain relief.
So we have 3 cases to bring all these nice points out. Good discussion. So is this a standing CT, Javi?
No, it's not.
Okay, but you this is what you picked.
Deborah wants to say something.
Yes.
Sorry, thank you, Bibiana. We've had some help using a SPECT CT scan to sort of find areas of increased activity. And we feel that if you've got increased activity on your SPECT CT, then the area is probably a pain generator. So we found that some coalitions are remarkably calm or cool on the bone scan, and others are really light up. And if we light up, and the patient's symptomatic, those are the ones that I'm tending to treat more at the moment.
Would you give us a few more words what that exactly is so our interpreter can tell the attendees who have no idea what you're talking about?
Sorry, it's a bone scan combined with a CT scan so that the areas of increased activity on the bone scan are correlated with the pathology on the CT scan. So you can have a coalition like this, which can either be active on bone scan or not active on bone scan. And we think that that helps us delineate whether the coalition is the source of the pain or not.
Bibiana, Dr. Castellini or Dr. Albarician.
Quisiera hacer un comentario.
Have you had SPEC CT available to you in Argentina? Have you had?
No, en el Garrahan.
Okay, Perry.
So it's a very nice technique. We use it also for the hip for AVN. Very helpful. Okay, so we take Javi through the case here, and here's your CT, and this is tells you what, Javi.
¿Podemos comentar algo más antes de seguir?
Sure.
Yo acá encuentro 2 pacientes que tenían esta barra oblicua que operé, no tuvieron un resultado. Cuando uno tiene una buena relación médico-paciente, eso un poco ayuda, pero he encontrado que el síntoma principal en estos casos suele ser un túnel tarsiano, a pesar de que uno esperaría la contractura de los músculos laterales de los peroneos. He visto casos que está descrito, pero he visto más que lo que parece descrito, casos con síndrome del túnel terciano. Ahora, lo que encuentro en esta radiografía de frente es que tenemos un caso de escafoides, que es un escafoides de un grado 2 del Miller-Weiss o un pseudo Miller-Weiss, porque en el Miller-Weiss el talo va hacia la segunda cuña. En este caso es un pseudo Miller-Weiss, y eso genera un metatarso aducto. Entonces, este pie tiene una mecánica de marcha, cuando le hacemos el estudio de mecánica, tiene una mecánica de marcha alterada, que a mi entender no estaría provocado exclusivamente por la barra tarsal. Y esto es una de las cosas, junto con los resultados regulares, esto es una de las cosas que me llevó a mí a replantearme si solamente yendo a resecar la barra yo resuelvo el problema de la morfología de este pie.
Who's talking?
Jorge Castellini.
Oh, that's Castellini. Okay, thank you. Thank you. Okay, good.
So Perry,
Yes?
I totally agree with Jorge that we tend to look at an X-ray or CT scan and think there must be friction causing localized pain, but the deformity is perhaps more important. And with the perineal spasm, which is not well understood, one option you can do is Botox in the perineus brevis, or if it's unremitting, when you do the surgery, you may transfer the brevis to the longus to remove a deforming force.
So those of you who don't recognize the voice, that's Peter Stevens from Salt Lake City. So good comments. So then you took this X-ray here. How does this help you, Javi?
So these coalitions are quite variable. And as mentioned before, you can have some degree of deformity. And that deformity needs to be evaluated in each segment. You can have hindfoot valgus, you can have midfoot abduction, you can have forefoot supination. So I usually use the Saltzman view, which is the one on the right side, to evaluate hindfoot deformity. I don't have access to a weight-bearing CT scan, which I think is going to change the game in evaluation of the deformity associated with these coalitions. So I use clinical exam and the Saltzman view to decide on whether do a associated correction of the flat foot deformity plus the resection.
So it's a very active discussion. And if you go to our meetings, there are some proponents of, if you're going to take the coalition out, then leave the deformity alone and quote unquote, the foot will loosen up and then you look at deformity later. I think the majority of us, if we're going to do coalition surgery, which is a decision you must make, would say with a deformity as we see here, we probably need to do the coalition resection and then at the same time correct the deformity. What I've experienced over the years, if I would take this coalition out, it almost invites the foot to fall into more valgus. That's been my experience. So I think assessing for deformity ahead of time, assuming you're a resector, in this case, 10 years old, is essential. And here's your 3D CT, right, Javi? Can you just quickly go over this for us?
Yeah, sure. I think the 3D CT scan is very useful to localize the coalition. In this particular case, it's a middle facet. You can see the posterior facet is healthy. So this is, for me, a resectable coalition.
Perry?
Jeff Johnson.
Yeah, so just, this is a beautiful example of why it is so difficult to see the plane of resection for your tarsal coalition, the talocalcaneal coalition, because as you can see on the most right-hand image, the sort of the plane of this cartilage synchondrosis is almost anterior to posterior. It's not medial to lateral. So when you approach it from the medial side, you don't see anything at all. And so it's just a beautiful example of why it's so difficult for us to find this. And I think the comments earlier about finding the joint above, finding the joint below, and then trying to find your way into the into the coalition is helpful.
Javi, take us through. Here you are opening up.
So we did, as you mentioned, a medial oblique approach. We found the subtalar joint from behind, so we separated the neurovascular bundle and then resected the coalition. There's a couple of ways to increase the resection to do it better. You can use navigation, you can use a CT scan intraoperatively. We don't have access to that kind of technology. In the last few cases, we've been using 3D models printed. We sterilize those and use it in the OR. I think it's very helpful, and that's cheap.
This is this is where I would incise. You may have. I would incising the posterior capsule of the subtalar joint here, protecting the bundle and the long toe flexor, I think helps loosen this up. Does for me.
Yeah, I totally agree. I think you need to do the capsulotomy to increase the mobility in that joint.
Okay.
And then we used fat graft from the gluteal crease. And then we approach the deformity.
Dr. Eastwood, when you do this resection, do you at the same time plan to do the deformity correction if you think that's going to be there? Or are you one of those that say, well, let's resect the coalition, this is a young patient, and see what happens to the deformity? Which way do you go, Deborah?
I think if there's significant deformity, I do the deformity at the same time.
Bibiana, how about you?
Sí, sí. Justamente en el panel están preguntando eso, si después de la corrección queda valgo, se corrige, nosotros hacemos una osteotomía del calcáneo para corregirlo.
At the same setting, right?
Sí, en el mismo tiempo.
During the same operation as you do the resection, you do the deformity correction, correct, Bibiana?
Sí, sí, sí.
So your thoughts here were, as we see, can you keep going, Javi?
Yeah, sure. So in this case, the patient had a hindfoot valgus deformity plus midfoot abduction. So in those cases, I usually use, so you want to go back to the first, yeah.
Yeah, I'm showing the midfoot abduction for those who forgot.
Yeah, for those that are not familiar with this X-ray, the AP, weight-bearing AP, you can see there's some uncoverage of the talonavicular joint and also the line between the talus and the first metatarsal are not collineal. So that's an objective way to evaluate midfoot abduction.
How much weight lengthen?
I'm sorry.
Your lengthening is 10 millimeters, 9 millimeters?
Yes, I think 10 millimeters is what my top. I wouldn't do more than that because I would increase pressure on the CC joint. So if I have this deformity and I need more correction, you can add another osteotomy, and I think we're going to discuss that later. But usually if I have midfoot abduction, I start using a calcaneal lengthening osteotomy. And if I have only a hindfoot valgus deformity, I use the calcaneal medial sliding osteotomy.
Any comments, Baxter or Peter?
Yeah, I try to evaluate these patients preoperatively and decide, am I going to do a reconstruction at the time of the coalition? One of the comments that Jeff had is one of the factors in decision-making. I think after a subtalar resection or a calcaneonavicular for that matter, you want to get motion going fairly quickly. And when you do a reconstruction, you have to immobilize these kids in cast. So you have to balance that equation. And we have some people in our group, as a consequence, if they're going to do a reconstruction, they would do it secondarily at a later date after resection.
Dr. Castellini or Juan, any additional comments before we move on for another case?
Yo tengo un comentario que es un poco disruptivo, porque estos pacientes...
Who's commenting?
Jorge Castellini.
Okay, thank you. Go ahead.
Estaba diciendo que en estos casos he visto en el posoperatorio que el tiempo de contacto del pie en el medio pie está prolongado y mucho, incluso después de la operación. Lo que me llevó a pensar que la operación de la barra tarsal no es suficiente y explica muchas veces los casos que han sido evaluados previamente y en el posoperatorio y que no modificó la mecánica de la marcha. Entonces muchas veces nosotros tendemos a ponernos contentos cuando el paciente está conforme y dice, no, estoy mejor, pero cuando el paciente viene con quejas y yo vuelvo a medir con baropodometría dinámica y encuentro que hay un aumento del tiempo de contacto del medio pie que es patológico. Y es un caso que se ve patológico desde que es muy joven hasta que tiene muchos años. Y es algo que me inquieta pensar dónde podemos nosotros intervenir para mejorar ese tiempo de contacto. O sea, la pregunta es, ¿qué operación disminuye el tiempo de contacto del medio pie para evitar el colapso progresivo que se ve con los años?
Dr. Johnson, can you answer that question?
When Dr. Castellini talks about increased contact time during stance phase, I'm interpreting that to mean a limp. Is that correct? I mean, during walking, there is a limp, even though the patient may not complain. Is that, am I understanding that?
No, es un estudio de diagnóstico, la baropodometría dinámica o pedobarografía dinámica permite evaluar de manera cuantitativa cuál es el tiempo de contacto del sector, que en este caso se divide en heel, midfoot y forefoot, y también a qué velocidad va la fuerza. Y estamos haciendo un trabajo en adultos donde podemos observar que el midfoot contact está prolongado y que estaba prolongado antes de la cirugía. Y eso me lleva a ver que la cirugía no necesariamente modifica la biomecánica de ese pie. Insisto con que hay algo más que esa barra en ese pie y eso es lo que me genera cuestionamiento, ¿verdad?
Yes. My feeling is that even though we resect the coalition, that actually what we are accomplishing is perhaps only a removal of a pain generator. But in my experience, I don't think we often achieve meaningful subtalar joint range of motion or an increase subtalar joint range of motion. And perhaps it's this stiffness of the subtalar joint that is persistent even after surgery that is causing these gait abnormalities.
So your patient eventually, I think, did quite well, Javi. And I assume you've seen him for a couple of years. He's now, what, 13, 14 years old? Is he doing okay?
He's 2 years from that surgery and he's got a very good mobility. I'm sorry I didn't put the video there, but there's good alignment. The pain is being relieved and he's got good mobility, so he's doing sports and everything.
So same issue. It seems like a very important issue to all of us. Different patient. My patient, 14 years old, stiffer, bigger, more deformity.
Perry,
Yes, who's talking?
Albarracín, quería preguntarle a Perry y a Javier cómo manejan el postoperatorio cuando hacen la osteotomía al mismo tiempo. ¿Cuál fue el postoperatorio?
Okay, let's finish the case. Okay. We'll go through this case and then we'll talk about that at the end of this case because it's very important in this particular case. So similar deformity, bigger deformity, bigger patient, bigger problem. Heel valgus, forefoot abduction, and there's a significant coalition. Note on toe standing, a little improvement on the right side, an asymptomatic coalition, so to speak, on the right, but a symptomatic coalition on the left side, more deformity, stiffer foot. Suspected coalition, and there's the deformity, and obliquity, fibrocartilaginous with a lot of deformity. I think a real challenging situation. So we don't have standing CTs. I was thinking Javi might have that, but we don't have it. Dr. Johnson's talked about getting it. Peter Stevens, have you seen, do you guys have standing upright CT, weight-bearing CT in Utah?
We don't at the Children's Hospital. We do at Dr. Salzman's clinic. Another point to mention though, on plain radiographs, you should always have a weight-bearing AP of the ankles to rule out ankle valgus because this can coexist or be a factor. I don't think it is in this patient, but with ankle valgus, it can look just like that picture. So it's wise to know that before you undertake foot surgery.
So we've talked about this quite a bit. And so our plan, looking at this, my plan was having had not good results from just doing a coalition resection without addressing the deformity at the same time. Jeff and I have gone over many of these together, and I would consider a comprehensive approach to this, including resection of the coalition. But I think it's far too simplistic to assume that taking out this coalition is going to improve the gait pressure readings as we just talked about afterwards, or the problems the patient has with his discomfort and the deformity. So for sure, we would resect the coalition, right or wrong. And we would consider osteotomies for residual deformity. Last case of Javi, 10 years old, I concur one lengthening of the neck may be what you need. So in this particular situation, we would do the lateral column lengthening, a small amount to help with the forefoot abduction, but the heel valgus won't respond that much in an older patient to the neck lengthening. So we would do a medial calcaneal slide to finish our surgery, may or may not need to do a heel cord lengthening adjustment. So there's the coalition resection we saw before. Midfoot abduction, deformity. We're going to do a lateral column lengthening. And Dr. Johnson, you have talked, Javier referred to it, in the adult literature. What is the pressure change at the CC joint as you lengthen your neck? What are your understanding of that or your feeling about that, Dr. Johnson?
There have been several biomechanical studies, but one of the earlier ones was by Paul Cooper at Georgetown, and he simply just on a cadaver specimen took a 1 centimeter block and placed it into an Evans calcaneal osteotomy and noted that the contact pressure in the CC joint increased by 9 times. And the contact pressure was not evenly distributed at the CC joint, and it was the pressure was concentrated on the superior aspect of the calcaneocuboid joint.
Jeff, slow down just a little bit so they can catch up. Go ahead.
Okay. So when patients do have pain after this procedure, often it is because too much pressure on the calcaneal cuboid joint, and you will often see the arthritis on the superior aspect of that joint, as which would be typical of this the biomechanical study. So I think the point that Javier made about not overstuffing the osteotomy is a good point.
So here's our procedure, and I think it made midfoot abduction and reduced the navicular back where you like to see it very nicely. But the heel valgus, looking at the foot as we would after doing this before we make this decision, was also addressed by a tuberosity slide osteotomy. And here you can see we slid the tuberosity. I was very pleased with the outcome for this patient. Here we are pre-op. And this was a basketball, actually a very active basketball player. I'm not sure which one of the procedures I did made it better, but here's this deformity pre and post. You can see by the comparative arrows. And there's the posterior view. And he's back playing for now several years, competitive basketball, and the foot isn't much more mobile, but his medial and lateral pain he used to have is gone. So I think this is a challenging deformity, and I hear all kinds of different feelings about this. I understand why. This has been my experience over the years as to what you must do to deal with this. Anybody on the faculty make any comment about this case? We have one more with the same deformity with even a worse problem. Any comments, Peter or Baxter or Dr. Castellini? Anybody before we move on?
No, I would have approached it the same way. I noticed he has dorsal scars. Did he have an anterior tib transfer or some other procedure?
No, sir.
Okay.
Deborah?
Mi comentario está relacionado con que nos debemos todavía una evaluación alejada, con un follow-up muy largo, porque el colapso progresivo del pie que se ve en la gente mayor, que nosotros le empezamos a dar importancia allá como después de los 60, 65 años, se presentan de otra forma, o con alus valgus, alus rigidus, y muchas veces tienen como antecedente operaciones del retropié. Entonces nosotros nos debemos una evaluación alejada de estos casos para ver la evolución natural postoperatoria, y me parece que es interesante. La resolución inmediata es muy buena y el paciente queda conforme, pero este paciente va a vivir muchos años, en el mejor de los casos, y me parece que eso es algo que tenemos que analizar y evaluar.
Well, we have an experienced adult foot surgeon on this call named Johnson, who has a little gray hair and a lot of experience. Is there such a study that's been done, Jeff, or your thoughts, long-term outcome of this?
And the chat is commenting about residual stiffness in these cases, Jeff, as well, and whether that's a problem.
Your long-term experience with this, Deborah?
Oh, sorry, I didn't mean to interrupt. So I think we should have Jeff's comments.
Well, no, Deborah, I think your experience might be very, very helpful too. I mean, I'm not sure I share the same experience of seeing patients with a collapsed foot deformity in adulthood that had this type of surgery beforehand. If any, and I think in order to have that collapse, mobility at the subtalar joint is very necessary. And I think in these patients, if anything, the mobility in the subtalar joint is limited. So maybe from arthritic changes in the midfoot or something, there will be collapse. But I would not have expected this group of patients to go on and have a progressive collapsing foot deformity as we might see in patients with posterior tibial tendon insufficiency, for instance.
Yeah, as I agree. I mean, my feet are stiff, hopefully less painful and better looking. But it's the hopefully bit that I hang on to. But
14 years old, left foot pain in Chopard's joint, medially and laterally, as you see by the arrows, and the ankle. Difficult problem. It's really a problem when they show up at age 10 and they already have significant pain elsewhere because there's a big coalition in the subtalar joint. So the subtalar joint you should be able to see is poorly visualized. You just don't see it. So you should have a high suspicion looking at here that there's something going on here in the subtalar joint that isn't correct. As Javi showed us before, there's a large coalition here. And I show this here now with the CT scan cross section. And I think this is a very debated deformity in all worlds. This is a 14-year-old person. And I would say in my younger years, I may have been, I think, naive in thinking I could take this down and fix this. But Dr. Johnson has shown us that maybe this is not where you should go. Maybe there's other ways to treat this deformity. And so I'll show you what we did. But anybody would like to speak before I show what we did about how to approach this, please do so at this point. The pain again on this patient, on Javi's patient, 10 years old, if I remember, the little patient, you should be able to get localized pain early before you have a lot of stiffness and else problems in the foot and ankle. But this patient, when she presented, you know, there wasn't tender, it was Chopard's joint, both sides, middle foot, midfoot, hindfoot junction, and the ankle was sore. Foot was very stiff. Ankle's motion was okay. So we're here. Bibiana, any thoughts how you would approach this?
Yo lo abordaría con la misma incisión que estábamos trabajando anteriormente, Perry, igual.
In your approach to the problem, would it be what would be your surgical the procedures you would plan to do for this? Would it be a coalition resection? Would it be osteotomies around a stiff subtalar joint? Would it be rearranging the subtalar joint?
Primero haría la resección de la barra y vería el componente que queda luego y posiblemente alinearía el calcáneo. Posiblemente, no tengo que ver en la cirugía qué hacer.
Okay, I was intimidated by how big this coalition looked. So, Bibiana, I was concerned after I resected all this, I wouldn't have much subtalar joint. So you may be right, and it may have been a better result to take this out and then do osteotomies around it. So what I did, I worked around the
Sí.
Go ahead. So rather, we decided to work around the coalition and leave the coalition intact. Again, there's heel valgus, too many toe signs, forefoot abduction, left foot. And so I would approach this with probably 2, maybe 3 osteotomies. And we did that. Here's the neck lengthening judiciously being done, just showing with an instrument what can happen. We can reduce the midfoot abduction quite nicely with this. Not an extensive lengthening. I used 2 screws to stabilize this coalition or this osteotomy. As is the Giannis, the slide pictures, I slid the tuberosity generously. I didn't touch the coalition. I was intimidated by it. So as this crude diagram shows, once you correct that, there's a compensatory supination that has been there all along. You must correct that or you don't get first-rate contact on the ground. So we had planned, and again, excuse the crude diagram, but that's the best I have. So we plantar flex the first ray. Right thing to do, wrong thing to do, Javi? We do too much? Should we have done the coalition? What do you think?
So I totally agree with the approach. I think this kind of coalition, bony and large, are difficult to resect and the outcomes are unpredictable. So I would approach the same. I think the two options you have there, one is to do a subtalar arthrodesis and then correct the associated deformity in the forefoot, or you can work around the coalition. In my hands, working around the coalitions with osteotomies, like you showed, is easier. And we publish a series of cases with this approach, and all the patients are doing very well. And I think this is a very good approach for these cases.
Our biomechanist assessor, Dr. Stevens, any comments?
There we go. Yeah, I agree with this approach. I don't think a solid bony coalition such as that is causing the pain. I think the deformity is causing the pain, and you've addressed that nicely.
Oops. Yeah, so anyway, so I've tried to take this coalition out and like this, and I've failed. Bibiana, have you succeeded with, I mean, would you have also done osteotomies? I think you said, Bibiana? With your coalition?
Claro, sí. Sí, claro, hubiese asociado las osteotomías. Sí. Posiblemente hubiese quedado igual que el resultado final de ustedes.
Right. And we have cases, I didn't show them here, in which...
Juan Pablo quiere comentar algo. Juan Pablo Barracín.
Pregunta es más para los que cuando hacemos
Please.
y hacemos las
Proceed.
Parry y Javier, si hacen una síntesis más rígida para dar movilidad más precoz, es decir, con placas o con tornillos, de manera de movilizar precozmente el pie, como se planteó antes, que algunos hacen la resección primero en un tiempo y en un segundo tiempo hacen las osteotomías de calcaño y de Evans, de deslizamiento. ¿Usan algún tipo de esta síntesis más rígida para tratar de movilizarla? ¿Y cuál es el postoperatorio que ustedes usan si hacen las dos cirugías al mismo tiempo?
Okay, I can tell what, I mean, so what I do, and it wouldn't be so much for this patient because we didn't do the resection down, and we could answer by going back to this case here. What I do in this case, to answer the question, 2 osteotomies and a coalition takedown. So I would compromise here, and at 4 weeks, I would start some gentle motion. If I just did the coalition resection, you start motion as soon as the patient can tolerate that, which is within a couple weeks. If you just did osteotomies, I would immobilize for 6 weeks. In a situation where I've done both osteotomies and coalition resection, I go about 4 weeks and then start motion. So that would be my answer to your question. Baxter, what would your approach be when you've done osteotomies with resection coalition?
I tended to do exactly the same thing, Perry. Use screws for fixation so that I feel confident that at 4 weeks we can get them moving. So I would do exactly the same thing, not immobilize 6 or 8 weeks.
Peter?
Deborah have comments.
I didn't understand that.
I just written in the chat that to be controversial, I might have corrected the deformity at the subtalar joint level and gone for a fusion.
Would Jeff have done that?
I'm sorry, this case here.
And the one which had the most deformity in it, yes.
This one, yeah. You say that you would have taken the subtalar joint down?
Yes, and corrected the deformity at the subtalar joint and then fused it in its corrected position.
The next case, which I don't have time to show, so I didn't put it in, shows a much more severe deformity at the subtalar joint, much more valgus. And Jeff and I took the subtalar joint apart, rearranged it, and did exactly what you said, a more severe deformity.
Barry, can I make a comment on that?
Comment, yes.
So I think that's a good approach. However, the issue is that if you take down the coalition and do a fusion, you're just correcting the hindfoot valgus, and you're not correcting midfoot abduction, and also you're not correcting forefoot supination. So you need, even if you do a fusion in the subtalar joint and you place your calcaneus in a good position, you still, this is a three-dimensional deformity, so you need to correct the other segments as well.
Yeah, claro.
Deborah?
I've always thought that if the front of the subtalar joint was still mobile, that you got quite a bit of correction. So I take your point, Javier, but I've felt that you could get some correction of the forefoot by truly addressing the hindfoot well. But it's tricky.
This very stiff foot was very stiff when we were done, but she was asymptomatic and has remained that. There's the pre-op and post-op comparative pictures, and the excuse the incisions, but she, her foot no longer bothers her. She's quite satisfied with a foot that's stiff, remarkably so, but not painful. It's what amazing small change makes for the ankle to feel better. I mean, thank goodness. So I think unless anybody has many more comments about talocalcaneal, I think our discussion is excellent. We will get through what we can here. We won't get through the whole program today, but that's okay. The discussion I like. Any more comments about talocalcaneal before we move on to calcaneal navicular coalitions? Anybody? Javi or Dr. Castellini, Albaristini?
Yo la verdad que me ha pasado de hacer resección completa de la barra y del subtentáculum tali también con buenos resultados. ¿Alguno en el panel tiene experiencia?
I didn't understand the question. I'm sorry. Who was talking and what was the question?
Juan Pablo, Barry, my question is, I just not resect the subtalar fusion, the subtentáculum tali, or the tentaculum tali, like John did 20 many years ago.
Could you translate that, Lydia? I didn't understand it.
Pablo, decilo por favor.
No solamente reseco a la barra, sino también reseco todo el subtentáculum tali, de manera que quede totalmente libre la parte medial. Si tienen experiencia alguno con esa forma de approach.
Anybody, Jeff or Baxter or Peter or Deborah? How about taking out the whole sustentaculum tali when you do your resection of your coalition? I have not had any.
Baxter here. I haven't either.
Peter?
No, I don't. But if I took the whole thing out, I would be tempted to just correct the calcaneus under the talus and perform an arthrodesis.
Jeff or Deborah?
I suppose I still don't quite understand. I mean, if you're resecting the coalition, you've got to take out all the coalition. So if you're, and that can effectively mean most of the sustentaculum tali, and that's why we run into problems. So if I am going down that route, then I have to make sure that the hindfoot is stable and well aligned at the end of the procedure.
To conclude, Jeff Johnson, what happens if we take out, in your experience, the sustentaculum tali in this resection?
I have not done it. I think the feet are pretty stiff anyway, but there are some, important, ankle ligaments that are attached there. And The other thing is there's a shelf under which the flexor hallucis longus should reside, and I try to leave that shelf so that the FHL stays in its anatomic location. We talked earlier about the FDL, the flexor digitorum longus tendon, sliding into the gap that has been made by the coalition resection. I try to save some retinaculum and sew it and imbricate over the top of the coalition so that the tendon does not fall into that gap. So I think that could even be worse if the whole coalition is resected.
Bibiana, can we move on to calcaneal navicular? Have we discussed this satisfactorily as far as you're concerned?
Hay una sola pregunta de un panelista que dice cuando hacen más de 2 osteotomías, si han tenido algún síndrome de Sudeck.
Have anybody seen that? Jeff or Baxter or Peter? Have you had a lot of pain difficulties with too many osteotomies? The question is, or Deborah?
I wouldn't like to say it was a true Sudex, but I mean, I've had some patients who are very slow to mobilize and the foot looks quite unhappy. So I think these are potentially big operations and the perioperative care is crucial. So I've had unhappy feet, but have I had a long-term problem? Not particularly that I'm aware of.
Yes, I agree, Deborah. These are big surgeries, and I think that when you can, placement of these skin incisions well away from each other is important. Trying to do minimal dissection. We have, or at least I have in my practice, transferred over to doing a minimal incision type calcaneal sliding osteotomy to try to minimize some of these incisional problems and just the morbidity of the surgery.
Any additional comments by Baxter or Peter?
No.
No.
Schumann Lou, are you on the call?
Yeah, I'm here. I just fixed my computer. Sorry, I'm late. Yeah, and for this case, I just finished one, and this one I cut bridge and I put a screw to orthodesis to correct valgus deformity. So almost same as Dr. Peter Stevens.
Okay, Bibiana, can we move on to calcaneal navicular? Let's do that. So this is a picture from JP.
Sí, por favor, porque si no, no llegamos a Cavo.
We aren't going to have time. We're having a very good discussion, and that's the way it is. So we aren't going to get through it all. We'll have to figure out what to do, but we're having a very good discussion, and that's the most important thing as I see it. Oops, I'll slow down. Can you say that for me, Lydia? I think the discussion is more important than covering all the topic. Okay.
I have just, tengo un solo comentario más que es una opinión general. ¿Qué les parece el funcionamiento del flexor largo del hallux en el mecanismo de Windlass con respecto a si sacar o no sacar el sustentaculum? ¿Le dan alguna importancia al Windlass? ¿Le dan alguna importancia a la evaluación clínica en el preoperatorio sobre si tiene o no tiene una rigidez del antepié por el flexor largo del hallux?
A question for anybody on the panel. Peter, Ira, Jeff. I don't do that.
In my experience, I have not observed any contracture or entrapment of the flexor hallucis longus as part of this coalition problem.
Calcaneonavicular Coalition, our next topic. And we will probably not get through CAVUS, but we will have a good discussion. So I think this is a very nice article in showing this deformity. It's a reference there if you'd like to look it up. And again, the surprise for this is for the uninitiated or for the initiated. Every time we go in to do this, the coalition is a lot larger than in our heads we imagine. It's as big as you see there. So oblique incision probably is a little more risky for the superficial nerves, but it takes you there, I think, easier than making a very lateral longitudinal incision. Jeff, what's your preferred incision?
Well, I am, as an adult orthopedic surgeon, primarily, I am affected by my need to come back later and do revisions of some of these surgeries. And so therefore, I prefer a more extensile incision, even though this incision gives you great access and is very cosmetic, it is not very extensile.
And I know what Javi does. Peter, your preferred incision here? Peter Stevens? Baxter?
I do this exact same incision, Perry. Despite what Jeff says, hopefully I resect this sufficiently enough that you're not going to have to come back and do an extensile approach in this area.
Deborah?
I do the same, I'm afraid. I'm a pediatric orthopod.
Juan Pablo?
Lo mismo, el mismo horario.
As we see here,
Exactamente.
same as we
horario.
see.
Mismo horario.
Dr. Castellini?
Sí, sí, el mismo.
And we know exactly what Javier does. He has these beautiful pictures, carefully reflect the short extensors, as we see here. I can't emphasize, I think, enough when you do this to respect the other joints that are there. I've seen a lack of that by people doing this in the past, which bothered me. So to get the exposure through the incision I show is much easier for me with this incision than the extensile incision Jeff's talking about, which I've also used. And I understand exactly what he's saying. Jeff works on older patients and has to deal more with the aftermath later in life of problems or dealing with more difficult problems in older people, I think. So I think exposure here is challenging. The coalition is big and you have to get in without injuring other things. So we expose over to the navicular. Complete exposure is essential for a successful resection. So it looks enormous. I'm sorry it's not quite so focused, but you do find the parts. There's the navicular. When it's magnified like this, it looks a little bit bigger and grosser than it really is. There's the talus. For the unexperienced, you know, we try to do this without injuring this joint. And you come down here, there's a large coalition. There's the calcaneus. So the extent of the resection is significant. So we had a question for Ira. Are you done fixing your hip? Have you joined us? For those of you who don't know, Ira is from Detroit and he called in earlier. He is operating this morning on trauma. So let's field Ira's question to London and have Deborah Eastwood kind of tell us how she ensures enough exposure. I know she's done a lot of coalition work.
I don't mean to sound arrogant. I think this is a lovely operation to do. I think it's quite an easy one to do if you know your anatomy. So with the sinus tarsi on one side and your preoperative planning and identifying the calcaneal cuboid joint, I think you can and should, of course, get a picture that looks very much like the one you've done.
What does lovely mean, Deborah? What does that mean? Lovely. Can you say lovely into a meaningful word in Spanish, Lydia, so they understand what lovely means anatomically, or what? I'm sorry, Deborah, I just had to say that.
I know. It's a very English thing to say. I appreciate that. A very anatomically, I don't know, interesting operation to do.
Don't go too fast. Lydia's got to keep up, and so does Marina. So keep going. You're doing great.
No, I think it is a beautiful depiction of the pathological anatomy. And if you've done a careful dissection, and I totally agree that you've got to preserve those soft tissues that you're taking off effectively off the sinus tarsi. If you preserve those tissues and then expose the coalition and the neighboring bones and joints, then you should not be able to go wrong, because you've got the anatomy sitting there in front of you.
Bibiana, given this exposure, what instruments or tools do you like to start with in taking out the coalition?
Yo lo que hago en quirófano es exponer, como dice Debra, toda la anatomía, que sí es hermosa, y marco lo que yo creo que es la barra y después con radioscopía. Y me fijo si realmente es la localización y la extensión adecuada a lo que yo vi en la tomografía.
What do you like to use for instruments to take out the coalition, Bibiana? What tools? Osteotome, Roger, saw.
La marco con escoplo, no con sierra.
And what do you excise it with? Osteotome? Rongeurs?
Sí.
Burr? Okay. So here is, I'm sorry, this is an osteotome here on surface. And then we are doing more work with the rongeurs. And then with the burr. And Dr. Mosquijo, can you comment about your concept about the shape of the resection here and how you get this out and not injure the adjacent joints, Javi?
So I usually use freer elevators to protect the talocalcaneal, the talonavicular joint and the CC joint. And I resect it with a 5mm osteotomes. And also I use rongeur and occasionally a Kerrison for the most plantar aspect of the coalition.
Which is down here with, yeah, which Javi, you agree with, is down where the caretta is pointing, where the Kerrison is a nice instrument to put down in here, correct, Javi?
Yeah, that's correct.
I think Lydia's got to catch up with us here.
Yeah, I think the special attention must be taken to resect the plantar periosteum to avoid reossification. And then once you have done that, the plantar muscles are visualized in the depth of the defect.
I concur with the concepts of beautiful and lovely, but I wouldn't use those words in the OR because I guess it's a gender thing a little bit. But I think this is a neat operation and it should look good when you're done. And I think Javi put words in my mouth here with the next slide, but there we have the parts and you have to continually remember everything is. The fellow or whatever you want to call them learning are just eager to dig all this out, but you want to leave joints, cartilage intact. And you must continue to remember you are, so it's big. And when you're there, as Javi just pointed out, I can't believe he said it, but here we go. This is my job when we do this. I know where the CC joint is because people forget what they're doing and they take too much out sometimes. I know where that joint is. and I do exactly what he said. My job is to put the freers in there and to protect these joints. And my head is pushing other heads out of the way constantly with my headlight to show them about what they're not supposed to injure this joint or this joint down here or this joint here, but they're supposed to get this out adequately and completely. Jeff, you are a thorough, unbelievably complete surgeon. How do you do this?
I except for a more longitudinal skin incision,
Yeah, okay, we're beyond the skin incision.
Basically approach it the same way. I have stopped, elevating the insertion of the extensor brevis. I just split it. But in terms of the bony resection, I exactly, endorse what everyone has said. The one tool that I prefer at the end of the resection to make sure that all the surfaces are fully resected and smooth is a micro reciprocating rasp. So this is a tool, it's a power-driven handheld tool that in many places has a saw attached to it, but you can attach a rasp to the end, and it's very easy to contour the surfaces, and the rasp does not as easily injure the joint surface like a burr. A burr is very aggressive and can more easily damage the joint. So I use a rasp.
And in our hospital, nobody but Jeff is allowed to use the rasp. It's locked up when he's not here. And we have to get permission. So we can't find permission most of the time. So we have to go to the more gross burr. Dr. Liu, do you do a fair amount of resections of this coalition in Beijing? And how do you like to keep the operation a safe one? Schumann?
Yes, I like use to rupture and osteotomy.
Osteotomy, you mean?
Yes, osteotomy and rupture.
Osteotome and rupture.
Yes.
Peter Stevens, you're a finesse surgeon, and I've been there watching you. How do you like to do this? We lost Peter's microphone. Is he still on? Sabrina, is Peter Stevens still on? Sabrina,
I don't see him, Perry.
Is he still on?
No, I don't think so.
Okay, Baxter, so how do you maintain joints here when you're helping somebody do this or doing it yourself?
As has been said, I use freers to identify and protect those joints. The other point I was going to make is that the trainees tend to put the osteotomes in and put them in a converging manner toward the plantar aspect of the coalition. So you want to start with your osteotomes being relatively parallel to one another as you go from superficial to deep in this coalition. But then I use exactly as others have said, rongeur, kerrison, curette, carefully protecting the talonavicular and the CC joint.
Juan Pablo or Dr. Castellini, any other thoughts about how you like to do this?
Débora tiene algo para...
Deborah.
Sorry, no, I just had remembered that I'd forgotten to say that I use the McDonald's and the Freer elevator as well, but everyone else has covered that point. So yeah, nothing more to add about that.
Dr. Castellini or Juan Pablo Albarracín.
Creo que un detalle importante es lo que dijo Baxter recién, que los escoplos sean paralelos y no hacer una cuña de resección. Eso es un detalle para mí muy importante.
Yo lamento no concordar con Débora con respecto a que es una cirugía hermosa, porque siento que voy todo el tiempo en un límite, por un lado de preservar las articulaciones y por otro lado de resecar lo necesario, porque hay una tendencia a irse de manera triangular hacia abajo y entonces se hace complejo. Así, utilizo los mismos elementos, el mismo instrumental, pero no voy tan amorosamente. Me resulta en un límite muy cerquita entre lesionar y quedarme corto.
I think we have an issue here regarding a gender description of things. So it's all good fun, but I think we have a male gender description of things and a female gender description of things. So I understand. Can you translate that, Lydia? or Marina? I don't mean in good fun. I think I agree. I'm sure it's lovely what I do, but I think the outcome's very nice. And I think that's what either Dr. Albarracin or Dr. Castellini said. So we go on. How do we know we have enough taken out? Bibiana, what do you like to do to decide if we've removed enough? Dr. Dello Russo, how you decide? With the radiograph, with your examination of your finger, or what?
Con las dos cosas. Igual voy poniendo como está ahí en la diapositiva anterior, las FERTs para que no tratar de llegar a las articulaciones, siempre respetándolas, ¿no? Y lo más importante, a mí el detalle más importante es no resecar cuñas, hacer la resección en bloc, con los osteótomos bien paralelos.
Do you use the radiograph, Bibiana, afterwards?
Sí, uso intensificador de imágenes durante la resección para constatar si es suficiente.
Is this enough that you see here? This is an image intensifier.
Sí. Igual hay que darle movilidad. Yo clínicamente también lo testeo, ¿no?
Dr. Johnson, have we taken out too much here, or what do you say?
No, I think this looks very good. I agree that sometimes it looks like you might create instability at the transverse tarsal joint, but I think these are stiff already, and I think that looks good. I believe this X-ray is very important because if you have created a trapezoidal shape to your resection, you will see that you have not adequately resected it on this X-ray. And so I think this is important.
Dr. Liu, do you use X-ray to show how much you've taken out? Or how do you decide you've taken out enough bone, Schumann?
Yes. Yeah. I use X-ray to verify, and before I cut it, I use pin to mark it. Then I use X-ray to verify I fully correct it.
Javi, you've had a lot of experience and published on this. You would, I think, agree we took out enough here. What do you now plan to, and going forward, in minimizing recurrence? What's your thoughts about that? I know you've looked at this a lot, Javi.
So to minimize, that's a great question. To minimize recurrence, first of all, is the quality of the resection. As mentioned before, I think the margins in these resections are pretty good. I usually look at the oblique X-ray to see if there's a line between the cuneiform and the lateral cuneiform and the cuboid. That's my proximal margin. And another line in the CC joint. So that would be a 10 to 15 millimeters resection, which is perfectly good. Second is what you interposed. And I think there's evidence.
Here's the finger. Here's the finger. That's interposed. Is that, do you use that at all? Put the finger in there and.
It depends on how much your finger is, how big is your finger?
Mine's just average size.
So if it is 15 millimeters, it's fine.
Okay. So Deborah, we've already answered for you. So where do you like to go from here, Javi, as far as materials to put in here?
Is that a question for Deborah or for me?
No, it's a question for you. No, it's a question for
you. Okay. So I prefer fat graft taken from the gluteal crease. We published on this on JPO a couple of years ago, and we found that fat graft is better for recurrence rate. You can compare to EDB or extensor digitorum brevis. And I think that is because the extensor digitorum brevis is not large enough to fill the defect. And also because the EDB has osteoprogenitory cells that can create bone in the defect.
Other side of the ocean, the Atlantic, and your thoughts, Deborah, about does this make a difference or not, what you put in there?
I don't like putting EDB in. I think that's not lovely and it's not natural, and it gives a very ugly contour to the foot, in my personal opinion. So I like to repair the soft tissues rather than use them to plug the gap. I've not used fat. I have used bone wax in the past. I probably actually do nothing now and just leave a gap.
Dr. Dello Russo, what do you like to do at this point? Fat, bone wax, nothing? Bibiana?
Grasa. Grasa, nunca será ósea. Grasa.
Dr. Castellini or Juan Pablo?
Hace muchos años usaba el músculo extensor y luego nada.
Y yo uso grasa y el músculo extensor, las dos cosas como interposición.
Anybody else want to add?
Grasa y el músculo extensor como para interponerlo. Extensor corto.
I used to use the short extensor. I did it, I thought, quite well. I prefer to not do it anymore. I think the wound is better if you don't use it. And I couldn't see that it did much. I think bone wax or the fat, I've read Javi's paper. I know some of the material came from St. Louis for that. I think the jury is, as we would say, Lydia, in English, the jury is still out on what should be in there. So Master Johnson, who's looked over a lot of this, what is your thoughts here as what to do?
I think that, you know, I agree that there is no consensus on what to put in the gap. I think that early range of motion is perhaps the most important factor at trying to prevent reoccurrence. I don't know what the product is that others are using in terms of bone wax. We have seen very few problems that I would identify as a bone wax problem in the United States. I agree it can occur. So my question to Bibiana is, what are the problems she has seen with the bone wax?
Muchas veces ha surgido desde la herida, la cera, como un granuloma.
Oh. So perhaps we are using it differently. would use a bone wax only to cover the surface of the exposed cancellous bone and then remove any additional wax. Are you using the bone wax as a solid volume of material to fill the gap? Is my question.
No, la uso como usted dice con la superficie, pero he tenido reacciones igual, sin excederme del volumen.
Tengo una pregunta para el panel. ¿Alguien presta atención a la forma del escafoides y a su relación con la tercer cuña? Hay un aplanamiento que probablemente en la radiografía de frente se ve del lado lateral. ¿Alguien le da importancia a la evolución posterior a la resección de la barra a esta forma de escafoides? Vinculado con Miller-Weiss. Sí.
I have not. Deborah?
No.
Baxter?
No.
I may miss exactly I may miss the subtlety of what he's saying. I'm sorry. I have not. Jeff, have you seen any problems relative to the anatomy here at the lateral edge of the navicular?
No, I have not been aware of that. I assume the coalition could potentially affect that joint, but I have not seen a reliable relationship difference at that joint.
What I have seen, and some of my x-rays I've taken like this, is if you miss bone in this area right here. I think this is a bone that you sometimes forget to take out. That's what I've seen on x-rays I've taken. Now, maybe that bone doesn't reestablish a reconstitution of the coalition, but that's where I've missed bone. I'm sorry, we can't answer that question. So, okay, we put it there. So I would say, again, the exposure is extensive, whether you use Jeff's extensile longitudinal incision, which comes down paralleling the perineals, or this incision, it's extensive. The coalition is large. You know, resection must be complete. And I think the wound must be addressed, as Deborah has mentioned, with care. This is nice, beautiful pictures from Javi's video that he's put here, or the virtual he's made up. And I think the repair, I like repairing the extensive back where it came from. That's why I've stopped putting it into the coalition. I couldn't understand it after doing it several times what it did. And I know if you don't have this muscle there, this closure is sometimes, I don't think is good. You mentioned that, Deborah. I think it's better to have the muscles underneath the skin here for closure. Can you comment at all on problems you've seen with that or not? On the skin closure?
Well, I think skin closure, I've had less wound problems if I have extensor digitorum under there. And also I think, I really do think it gives a nicer contour to the dorsolateral aspect of the foot, which is maybe only a minor thing, but I think having grown up with those ugly feet following club foot corrections when we used to do big surgery, I think the appearance of the foot is important. And I think if you close it, as you show on this slide, then the wound heals well and the appearance of the foot is better.
And your post-op protocol, Bibiana, with just a resection, when do we start mobilizing the foot, Dr. Dello Russo?
Yo por lo menos a las 3 semanas.
Do you give any non-steroidal anti-inflammatories to try to prevent bone formation, Bibiana, or anybody? Bibiana, do you do that? I do.
Sí. Sí, naproxeno generalmente.
How long do you do that, Bibiana?
Bueno, hay que hacerle protección gástrica a todos los chicos, ¿no? Y más o menos por una semana nada más.
Okay, I've used 6 weeks of ibuprofen. Anybody else use any non-steroidal anti-inflammatories? Deborah or Baxter or?
Yeah, I like non-steroidals. I think they're good painkillers, and I'm not particularly frightened of using them in children. So I think it's good pain relief because, like others have said, I like to go for movement fairly promptly. So I say that I need them to be pain-free in order to move the foot. And I don't want them to be big and brave and not have the painkillers. I'd rather have the anti-inflammatories on board so that they can cope with a rehab program.
Baxter?
I don't use it for prophylaxis against reossification, but as Deborah said, for analgesic relief, and I tend to get these kids moving at 10 to 14 days.
Snap.
Non-weight bearing, but move their subtalar joint and their mid-tarsal joints early.
It takes a while to get over this operation. You know, if you think about it, you're going into the middle of the foot and doing a big operation. It's like an explosion. I've asked a couple younger patients, and I a couple years later, and that were patients that had, you know, themselves together in the head pretty good. And I said, how long do you think it was before your foot felt good? Now, this is a patient who 2 years later said, my foot is really good after all this. And a couple of young girls looked at me and they said, you know, I didn't tell them how much long. The one girl said she was 12 or so when I did this. She said, you know, it took 6 months before I realized I really was getting better and better and better. And this girl went on and did fine. I just did the resection, but it takes a while to get over this operation. It's a big thing to do. So I think we, you know, I'd like to have them move, but I don't insist they push themselves hard weight bearing. Dr. Castellini or Dr. Albarisim, what are your thoughts about how long it takes to recover from this for a younger patient with a successful outcome?
Yo particularmente los movilizo a la semana. Les pongo un férula y a la semana, ya cuando no tiene dolor, empiezo a movilizar, más que todo ejercicios de inversión, eversión, sin carga de peso hasta las 3 semanas. Pero que empiece a movilizar precozmente.
Yo presto mucha atención al cuidado de la herida, relacionado fundamentalmente por la intervención, porque no es una cirugía que hago rápidamente y entonces los separadores tienen un efecto de lesionar de manera relativa, ¿no? Pero por el tiempo de la cirugía, y entonces le tengo mucho cuidado a la evolución de esa herida quirúrgica. Mi intención es empezar entre 10 y 15 días con la movilidad precoz, y va a depender mucho del tipo de paciente, del tipo de entendimiento y por supuesto del dolor.
When do you think the patient will get back to playing soccer? That's for the same doctor who was just talking, Lydia. I didn't understand. Who was just talking?
Castellini.
Would you ask him when he anticipates the patient might get back to playing soccer?
En general, no menos de 3 meses, y es el paciente el que muchas veces viene y dice, yo estuve jugando, por más que uno haga una indicación, el paciente prueba solo. En general, no antes de 3 meses, es mi indicación.
I agree. Peter Stevens, did you get back with us or is he still gone? Okay, he's gone.
Desde el panel hay una pregunta del doctor Mosquera que dice que él tuvo un paciente al que trató con Ponseti por pivot, y a los 10 años le diagnosticaron una barra como esta, a la que resecó, pero el paciente persiste con dolor. Entonces pregunta qué hacer al respecto.
So this is a patient who had a clubfoot and then had treatment by Ponseti technique, but he really had a calcaneonavicular coalition as part of the deformity. Is that correct? You'll have to ask him.
Sí, es correcto, se la resecó, pero persiste el dolor y él pregunta qué hacer ahora al respecto.
It's a little tricky to know for sure without seeing the patient and examining the foot. Maybe Dr. Johnson could, if you understood the question, Jeff, maybe you could suggest what you might think you'd have to do for this 10-year-old with a painful foot, had clubfoot. Then they figured out there was a coalition between the calcaneus and the navicular. They took that out and it still hurts. What do you think you'd have to do, Jeff, just on a guess?
Right. I agree. Without seeing x-rays and exam, it's difficult. However, in the experience that we've had, that we wrote up, I think most of the kids that were having problems had some residual deformity. So I would look very carefully at the foot to see if there is residual deformity that was not fully corrected by the Ponseti method, such as a rigid forefoot supination or forefoot varus that is still there, or perhaps an overcorrection of the hindfoot being in too much valgus, perhaps. But it's difficult to just say offhand.
On the side, for those of us who 30, 40 years ago did a lot of PMLRs, about every 50 cases, I would find a big calcaneonavicular coalition, and I would take it down when I did it. That's just on the side. We're going to move on to finish this topic, and that'll probably be it today. But there's another issue when you do these coalition resections, and this is that patient. So this is a calcaneonavicular coalition. The anteater's nose drawn there, and you can see it on the oblique X-ray. It's a nice coalition. It's a pretty healthy foot otherwise. A little valgus on CT, but clinically this is a coalition that's bothering the patient. They're sore right over the coalition and they have deformity. So I think this is a little trickier as to what you do when you do this. And again, it gets into the debate. Scott Mubarak, who as many of you know is retired now. Sad to say he's going to do that, but I mean, he wants to retire, so he's retiring, but he was a strong advocate of the group of people who would take out the coalition, leave the foot alone, move them right away, and then deal with deformity later. I have always kind of felt my patients are better off if I corrected everything, the coalition and the deformity at the same time. Given the bit of a compromise you have to make, you can't move them quite so soon. The problem for me with this deformity is when I take out the coalition to deal with the valgus and the abduction, I want to do the neck osteotomy, and I'm concerned about doing that. So I'll just lead us right into what we're getting into. So I took out the coalition. I thought it was a nice resection. And then I'm going to want to fix the deformity in the foot, which was there. So this is the best I can show you without giving away what I did. How would you deal with this deformity if you felt you had to correct at the same time? Let's start with London, with Deborah. So we took out the coalition, but I was concerned that there's a little bit midfoot shift laterally and some heel valgus on this 12-year-old. and I want to correct that. Do I do a tuber osteotomy or a neck osteotomy? What would you consider doing here, if at all, Deborah?
Yeah, so to be honest, I don't think I've ever corrected the deformity at the same time as a coalition excision for a calcaneonavicular.
Say that again. Could you say that again slowly so we get that? It's a very important point.
So I don't think I have ever felt the need to correct deformity at the same time as excision of this type of coalition, a calcaneonavicular coalition. So I think I keep it simple, but accurate, take out the coalition, do a good closure, go for early movement, and reassess the deformity some months later.
Let's see. Juan Pablo, what would your approach be to this question? If you understand the question and make it clear. Coalition of calcaneonavicular.
Con un pie plano que está lateralizado. Yo habitualmente reseco la barra y tengo dos opciones, o hago una osteotomía de calcáneo y alargamiento de Van Mosca, o a veces he usado también, que para este caso creo que sería el ideal. No, en este caso tengo muy lateralizado el pie, sino a veces también he usado endoprótesis, que no sé si tienen experiencia con la MBA para usarlas para corregir el pie plano al mismo tiempo.
So you would do an osteotomy, or you would put in a arthroresis? Can you say that again? It was not clear. Can you restate that?
En este caso yo haría la resección de la barra y una osteotomía de Van Mosca, y no veo bien el talón, el retropié, para ver si tiene mucho retropié o algo, para ver si también conviene una osteotomía de deslizamiento de calcáneo.
Would you have any so he talks about, is he talking about a neck osteotomy? Calcaneal neck osteotomy?
Sí.
Would he have any concerns when he does that, if he's done a big resection of a coalition, that he may be compromising the circulation of the distal aspect of the calcaneus?
No me ha pasado, no he tenido problemas con respecto a eso, por suerte.
Is he any trouble with instability at the CC joint when he's done that?
No, me fijo con la clavija o uso una placa de osteosíntesis de calcáneo que tiene Wright.
Javi, what are your thoughts about how to deal with this?
Well, I think I would like to see an AP view of the foot, weight-bearing AP X-ray to see if there is mid-foot abduction or not. These calcaneonavicular coalitions usually don't have deformity, but you can see patients with planovalgus deformity, and also I've seen some CAVUS deformity associated with this type of coalition. So this could be quite variable. In this particular case, in this particular case, if there is, it seems like there is good coverage of the talonavicular joint, so I would go with a medial calcaneal osteotomy, medial sliding calcaneal osteotomy.
Well, let's see, Deborah, you don't correct at the same time. Peter and Ira are going. Baxter, have you had the occasion to correct deformity with a calcaneonavicular coalition at the same time?
I'm trying to reflect on that, but I think very, very rarely, if ever, have I done a simultaneous correction at the time of resection. I'm like Deborah, I think I've tended to resect these, and if there are problems down the road, deal with them at a later date, not simultaneously.
Dr. Liu in Beijing, if you're doing a calcaneonavicular coalition resection and you sensors also foot deformity. Do you do deformity correction at the same time? Or do you wait? If you do deformity correction at the same time, what osteotomy or osteotomies do you use?
I prefer to do it in the same time. And if necessary, I think probably I will perform calcaneal osteotomy.
Which calcaneal osteotomy, Schumann, the neck or the tuberosity or both?
Neck. Neck.
Anybody else want to say, to add any other comment? Castellini, any other comments, or Bibiana?
No, yo quería preguntar, el que lo hace al mismo tiempo, cosa que nosotros no hacemos, ¿qué posoperatorio realiza?
Yo estoy pensando en que es posible que la inestabilidad o la subluxación subastragalina esté vinculada con la presencia de la barra tarsal y probablemente no esté colaborando el Aquiles. Es posible que la cadena posterior esté acortada. Entonces, después de resecar la barra, pensaría más en un alargamiento de Aquiles que en una osteotomía de calcáneo, porque de todas maneras tengo tiempo de ver si al resecar la barra gano movilidad, puedo disminuir esa subluxación, incluso se podría medir con una weight bearing CT, con una tomografía con carga, o sea que me daría tiempo, pero trabajaría con el Aquiles y la resección de la barra.
Dr. Johnson.
You know, I think on the preoperative evaluation, I think it's really important to try to determine in your own mind whether you think there's enough deformity to be causing some of the symptoms the patient has. So I would agree. I think it's perhaps less common to have deformity associated with this tarsal coalition as opposed to the talocalcaneal coalition. But I still believe in the general principle that deformity can be a cause of pain. And I would agree with Javier's comments that a medializing osteotomy of the calcaneus is, I think, the best way to manage hindfoot valgus in a case like this.
Anybody else want to comment before I show what I did? So if we play cards or poker, we say, okay, call in your cards. Okay. Can you translate that, Lydia? Show your cards. Okay. Whoops. So I did a medial slide and it's turned out to be very, very good. I've had a couple occasions, I've done the neck osteotomy and the fragment of the distal calcaneus became very unstable, very concerning to me. Now, that might be that my resection is very extensive here. So I am nervous about doing a neck osteotomy. I don't know, either Dr. Castellini or Dr. Juan Pablo said they've had good experience with that. I'm a little concerned. So I've done this, I moved it a lot. I don't have long-term follow-up, but the patient has done superbly well. And so I bring it, the discussion with me was very, very helpful. And this is what I did. And I would like to see eventually a series published in which the comparison of the two osteotomies was done. Deborah said she is hesitant to do reconstructive procedures with this coalition. I totally respect that. It's different than the talocalcaneal coalition as to what else you might have to do. And these patients are usually younger than talocalcaneal, so maybe we could give them a chance. But anyway, I have a high degree of respect for the CC joint and instability of this fragment because in flat foot surgery and other things, I have produced problems here by getting too aggressive with the neck. I think Javi was a little cautious also. So this is what I did. Any comments? The patient's done fine.
¿Y qué postoperatorio hace?
Very, very good question. So in this case, I would do, again, I compromised 4 weeks immobilization, and then we start moving out of a posterior shell splint or moon boot, and weight bearing not until we have the osteotomy healing and they begin to feel comfortable where the coalition was. I have not felt that I lose that much motion. And I've listened to Dr. Johnson quite a bit, maybe more with the telecalcaneal coalition, that, you know, we get the foot repositioned, but the flexibility for the patient long-term maybe isn't quite as much as we think it is what we gain from. Maybe it's a little more flexibility from a calcaneal navicular coalition resection, younger patient than telecalcaneal. I go 4 weeks of mobilization, then I start motion. Dr. Who made all the good comments about the osteotomy of the neck? Was it Dr. Castellini or Juan Pablo? What's your post-op plan if you do osteotomies and the coalition resection?
El posoperatorio de 4 a 6 semanas, el posoperatorio con inmovilización. Es cierto que va en contra de la resección, de tratar de la movilidad, pero a las 4 semanas, ya a las 3-4 semanas ya empieza a movilizar con la férula, pero no es que empieza a movilizar completamente, pero empieza a mover un poco el pie como para que no esté tan rígido. Si no va a quedar rígido después. Vamos a parar lo que agarramos con la barra.
Is that Juan Pablo or Dr. Castellini talking?
Juan Pablo.
I'm sorry.
Juan Pablo.
So Juan Pablo, have you had any long-term problems with the neck osteotomy at the CC joint or with avascular necrosis of the distal calcaneus?
No, no he tenido complicaciones y muchas veces uso una placa de osteosíntesis que hace que sea un poco más firme y no permita la subluxación de la articulación CC, calcaneocuboidea.
Dr. Johnson, and seen follow-up patients that might have been done younger, have you seen any problems? Maybe not with osteotomies of the calcaneus combined with coalition resections of the calcaneonavicular type?
No, I haven't. I share your concern about either avascular necrosis or instability of the anterior calcaneal fragment if a Evans type lateral column lengthening osteotomy was to be performed. I think the medial displacement osteotomy is easy to do. I think more and more people are moving towards a minimal incision approach, which is even less invasive. And with internal fixation, movement can be done early. So I think it's a good combination.
We're going to conclude here. We have 2 or 3 minutes left, so we're going to conclude. We've discussed the stiff problematic flat foot secondary to tarsal coalition, as we see here on this patient's left foot. Let's discuss the next time we have a foot conference that we will be listening to Bibiana when to do that. So we're going to move on. And the next time we have a Saturday session on the foot for a totally different problem, too much mobility. The complaints would be lateral pain in ankle. In our part of the world, this is almost all secondary to Charcot-Marie tooth. Why would you see this deformity? And then we'll quit within a minute, Bibiana and Lydia. Why would you see this in Beijing? That's my last question. Dr. Liu, why would you see this deformity? Is it related to Charcot-Marie tooth? Did that make it to Asia? Because it certainly is why we see cavo varus in North America. How about in Beijing, Schumann?
For this kind of cases in Beijing, you mean?
Yeah. Yes. What's the cause? In North America, it's all secondary.
I think mostly is from CMT, Charcot-Marie tooth.
Charcot-Marie tooth. So you say, okay, all right. Okay. That will be the next topic. No, just bear with me. So we will conclude this is a quick review of what the next topic is going to be. It's going to be a good one whenever Bibiana lets us do it. I love the discussion this morning. We didn't get through half the program. That's not the point. The point is the interaction. We had a lot of faculty questions and answers, and I thank you all for bearing with this.
Hey, Perry, Perry, there was I noticed in the chat box that there was a question from one of the attendees about, my Spanish is not very good, but there was something about a percutaneous calcaneal osteotomy. Is that a question?
Ask that question.
Correcto.
So Jeff, why don't you comment on percutaneous calcaneal osteotomy?
Could someone translate the full question that the attendee had? Just so I make sure that we're addressing.
Si la osteotomía deslizante del calcáneo que proponían, alguna la hace en forma percutánea.
Yo la hago en forma percutánea.
Yes, I think that there is a trend to performing a calcaneal osteotomy percutaneously. There are a number of different companies that are providing instruments to do the osteotomy, such as a burr, and then also implants that can be used, either percutaneous screws, or there are some very small plates that can be inserted percutaneously to hold the calcaneus in its translated position. I have worked with some companies to provide, so I am somewhat biased in this, but what I have evolved to is the micro reciprocating saw, which goes like this, and it's placed through a very small incision, 1.5 centimeters, and using an image, the calcaneus can be osteotomized, translated, and then transfixed with either a plate or screws. It really does, I think, reduce some of the wound complications and morbidity.
We will conclude. So any final comments, Dr. Liu, about anything? Quickly. Schumann, any final comments? Quickly.
No.
Glad to have you with us. Deborah, any final comments?
No?
Yes.
All good.
Deborah?
No, all good from my end.
Peter's gone. Ira's never made a. Baxter, any final comments?
Excellent morning. Thanks to Jeff for coming along and giving his perspective. And thank you, Perry, for organizing this. Great morning.
So Dr. Albarisi, Juan Pablo, any final comments?
No, gracias. Gracias por la invitación de participar.
Dr. Castellini?
Muchas gracias, Castellini. Muchas gracias por la invitación y me gustaría que avancemos en la evaluación biomecánica, tanto de los prequirúrgicos, o sea, antes de operar, como los resultados de determinadas operaciones. Tenemos que medir biomecánicamente cómo funcionan nuestras técnicas quirúrgicas. Creo que es una obligación.
We will look for studies from you in the future, Dr. Castellini, in that regard.
I am doing a study with 1,000 patients with flat foot, trying to tratando de demostrar que tienen un patrón común en la mecánica de la mano.
Good, thank you. We will look for further studies from you. Javi, any final comments?
No, Perry, thanks for having me. It's been a great session.
Great to have everybody. Bibiana,
Sí, yo les quiero agradecer de todo corazón a todos porque esto fue excelente. Queremos saber que el 31 de julio va a ser la próxima sesión.
31st, it's right in front of you.
31 de julio, está ahí puesto para que todos sepan. Tenemos que programar también pie cabo.
Okay, we will then what we'll do on July 31st, Bibiana, we'll talk about CAVUS, okay? And then we'll have Eric finish in August, then we stop. Something like that. We'll think about it, Bibiana, okay?
Gracias a todos ustedes por participar.
And Dr. Mosquijo, you have a little comment to make about a meeting coming up you're putting together for Sclerotic and Pasta. Can you tell us briefly about that? And then we will conclude.
Yeah, thanks, Barry. Bueno, quería también invitarlos al congreso anual de este año de AAOT, de nuestra sociedad, que este año será en conjunto con POSNA y con la Sociedad Latinoamericana. Va a ser un congreso virtual los días 15 y 16 de octubre, y ya a partir de la semana que viene tendremos la posibilidad de hacer las inscripciones, y queda todavía una semana para que manden sus trabajos científicos, así que esperamos poder recibir sus trabajos.
Muchas gracias, Javier. Gracias a todos. Desde acá fue una magnífica sesión como siempre.